Hola, muy buenos días a toda la comunidad de la Sociedad Latinoamericana de las Inmunodeficiencias y buenas tardes para nuestros estimados presentadores que nos acompañan en directo desde París. Gracias por tomarse realmente el tiempo, especialmente un sábado, para unirse con nuestra comunidad por una misma pasión que es inspirar y profundizar en el conocimiento de los errores innatos de la inmunidad. Para el Comité Junior de la CID, realmente es un privilegio que aceptaran nuestra invitación y estén con nosotros. Good morning to the entire community of the Latin America Society for Immunodeficiencies, and good afternoon to our esteemed presenters who are joining us from Paris. Thank you for taking your time, especially on a Saturday, to come together with a shared passion that is to inspire and deepen our knowledge on immunodeficiencies. For the Junior Committee, it's a true privilege to lead this clinical session today. Dr. Jacinta Bustamante and Dr. Jeremy Rosain are two distinguished immunologists from the prestigious Imaging Institute in Paris, France, renowned for their leadership in the field of inborn errors of immunity. Now I hand the floor to my colleague Pilar for the introduction of our speaker.
Thank you, Alberto. It's a pleasure to introduce today's speakers, and thank you all for joining us at this session this morning. So we have the pleasure to introduce Dr. Jacinta Bustamante. She's a well-renowned pediatrician, immunologist, and researcher, widely known for her contribution to the study of innate immunity and her role in the defense against mycobacterial and fungal infections. Her work has been fundamental in characterizing molecular defects in critical pathways, such as interferon gamma and IL-12. Which has allowed significant advances in the understanding and clinical management of these conditions. Then we have also the pleasure to introduce Dr. Rosain. For his part, he's an immunologist and geneticist working in a nationwide clinical laboratory for immunodeficiencies. He's also working in the research lab of Jean-Laurent Casanova. There, he combines clinical and genetic research, highlighting the use of advanced genomic tools to identify new mutations and pathogenic mechanisms that contribute to the autoimmunity, autoinflammatory, and infection disease. Both have played a key role in integrating research into clinical immunology, promoting the connection between the lab and the clinical care. Their joint work has driven innovation in the diagnosis and personalized treatment of patients with rare and complex disease of the immune system. So we are really happy to have both here today.
Thanks, Pilar. Alberto, your mic is mute.
Oh, yes. Thank you, Jeremy. I was saying that we extend our sincere gratitude to Jacinta and Jeremy for joining us today. Thank you for taking your time this morning, your afternoon. So the floor is yours.
Thank you, Alberto.
Thanks a lot, Alberto and Pilar, for the invitation and the introduction. So I will maybe start and then give the floor later to Jacinta. Okay, can you see my screen in full screen? My slides in full screen?
Yes, doctor.
Yes.
So thanks again for the invitation. So I'm indeed a geneticist and an immunologist working in the clinical laboratory for immunodeficiency in Paris, and I'm also working a bit in the research lab. And so Alberto and the LASIT Junior Committee asked us to present you a few clinical cases of immunodeficiency, either inherited or acquired. So I will here is the outline of my presentation. I will just first talk a bit about some generality about how we see how we think that an investigation of an inborn error of immunity should be performed. Then I will present first some case of clinical cases of inherited immunodeficiency, and later some phenocopies. So just a quick reminder about inborn error of immunities. As you all know, it's a group of complex inherited genetic disorder caused by most of them germline variant, and it's a complex group of disease because they can be caused by more than 500 different genetic loci. And what usually primarily at the first as a first sign is most of the time increased susceptibility to infection, but they can have many other associated signs and symptoms, including autoimmunity and autoinflammation. So this group of inherited disorder is complex, and there is, as you all know, a classification for human inborn error of immunity. It's an immunological classification with 10 different tables that is regularly updated. And so the first line of investigation for an inborn error of immunity is really at clinical level. So there are various warning sign of immunodeficiency, as most of you know. So first of all, as we talk about inherited disorder, of course, familial history is important to search. Then it can be as warning sign recurrent infection to common infection, such as upper or lower respiratory tract infection, but at unusual frequency. And we think also that a single episode of invasive pyogenic infection should lead to an immune workup. Any unusual severe chronic infection or recurrent infection to the same pathogen should also lead to an immune workup. In pediatric, failure to thrive or chronic diarrhea are also important sign, and they can have also, as we mentioned, many other signs and symptoms, and organ lesion or pathological lesions that should raise attention to do an investigation for immunodeficiency. So pedigree tree are really key to establish. That sounds obvious to state, but it's really helpful to your clinical laboratory to have this information. If you are investigating a family in which there is a bit of consanguinity, this can orientate you to an autosomal recessive disorder. If you have a pedigree tree where only males are affected and females are asymptomatic, this can orientate you to an X-linked recessive disorder. And if you have individual sick at each generation, it can orientate you toward an autosomal dominant disorder. So how should we proceed to investigate an inborn error immunity? We think that there are three lines of investigation. So first of all, immunodeficiency is really defined at clinical level by the clinical phenotype. And the clinical investigation is really an important step. The familial history, but also all the history of the patient. Then What will bring unequivocal diagnosis will be most of the time genetics. And between clinical and genetic investigation, we have the chance to study disorder where we can also perform lab tests to better define the phenotype of the deficiency, and the immunological investigation are really key to orientate the investigation. And they rely on very basic tests that can be performed in most of labs that we will review shortly. So this basic immune workup include first of all HIV serology. So usually HIV serology in adult consultation is always correctly made, but sometimes in pediatric it's forgotten. So it's really important to always start with an HIV serology. For instance, a child who have tuberculosis should have an HIV serology. Also, there is a complete blood count, quantity and assessment of humoral immunity. So complete blood count is really a very basic lab test, but it will give you a lot of keywords. It will tell you if the patient has anemia, if the patient has thrombopenia, if the patient has thrombocytosis. It will tell you if the patient has neutropenia, polymorphonuclear leukocytosis, if the patient has lymphocytosis, lymphopenia, monocytopenia, etc. And for instance, if you consider the inborn error of immunity associated with isolated monocytopenia, they are among the 500, only 5. So you can see that with just a basic, very basic lab test, you can already have an orientation toward some more restricted number of inborn error of immunity. So it's very important to always interpret any lab test result to use age-adjust normal range. For instance, if you're 20 years old and you have 1.5 giga of lymphocyte per liter, it's a normal count. However, if you have the same level of lymphocytes at the age of 1 month, it's lymphopenia, and already a quite severe lymphopenia. Also, just of note, the manual blood smear review can provide you to the diagnosis of 3 different inborn error of immunity. So if you have OL jelly bodies, this can orientate you toward to an asplenia, and there are some cause of inherited isolated congenital asplenia. If you have a male patient with persistent thrombocytopenia, and that you perform a manual blood smear review and spot this micropalatelet, this can really orientate you toward a Wiskott-Aldrich syndrome or X-linked thrombopenia. Usually, when a patient has a peripheral thrombopenia, their platelets are big because they are renewed. And if you really have this microthrombocytopenia, this is really almost pathognomonic of a Wiskott-Aldrich disorder. And also abnormal pattern of the granule in granulocyte can orientate you with a Shediac-Higashi syndrome. We also recommend to perform a numeral immune workup with determination of IgG, IgA, and IgM titers in children. In adults, it's also important to perform serum protein electrophoresis, also to screen, for instance, for a monoclonal peak that could explain a secondary hypogammaglobulinemia. And again, it's always essential to use age-adjusted normal range because, for instance, in newborn and in children, the endogenous synthesis of IgG doesn't start before the age of 6 months old, and before all the IgGs that are present are the one originating from the mother. Another quite basic test is to determine serum specificity, to assess for the presence of specific antibody titer to protein antigen. So the most commonly used are tetanus and diphtheria toxoid, and this will tell you if the patient have impaired capacity to produce immunoglobulin to specific antigen. And then in second line, you can perform advanced tests such as immune phenotyping, in vitro proliferative response to mitogen and antigen, complement workup, study of oxidative burst, of total IgE level, and also a genetic study. So that's really the scheme of investigation. This may sound very obvious, but I think that for rare disease, you really need to be systematic to never forget anything. And even in our nationwide clinical laboratory, for instance, we most of the time when we receive samples to investigate, we don't have this information that can be really essential for the diagnosis of the patient. And so I will just start to move forward with some clinical cases. So Alberto asked us to focus on our cases as more on mainly on adult patients. So I will just give you share with you some atypical interesting cases that we had in adulthood. In adult patients. So the first one is a male of 50 years old. So when it's a male, you always have to think that it can be the three different inheritance, including X-linked recessive disorder. And the patient has a history of sinusitis and bronchitis, also several episodes of pneumonia, a severe chronic sinusitis, and he also starts to have organ damage because he starts to develop bronchiectasis. So which first line immune workup should be prescribed in this patient? So it's always the same as mentioned previously. So HIV serology, complete blood cell count, and humoral workup. So this is what was done in this patient. HIV serology was negative. He had normal blood cell count, and he had hypogammaglobulinemia with decreased serology titer to protein antigen. So he really had an immunological phenotype that justified to continue the investigation. And we did perform in this patient flow cytometry and found in this 40 years old patient complete lack of circulating B cells. And this patient had no history of B cell depletion therapy. So the association of hypogammaglobulinemia plus almost complete lack of circulating B cells, it's called agammaglobulinemia. And the most frequent genetic form of agammaglobulinemia is X-linked agammaglobulinemia, also known as Bruton disease. And we thus perform a genetic study in the patient and indeed identify an hemizygous variant in BTK. So why could it be of interest to identify a genetic disorder in a 40 years old patient? So one reason amongst other is to be able to perform a genetic counseling because his daughter are carrier because by definition they have received the X chromosome of their father. And in that case, we can the newborn, the male newborn of these two daughters will thus be tested early, and severe infection and lung damage in particular will be thus prevented in this new generation. And also for the patient, it gives him a definitive diagnosis. And also we know that in this case, he need to be supplemented with immunoglobulins. So overall, it was a discovery of X-linked agammaglobulinemia at the age of 40 years old. So another interesting adult cases that we had was this 60 years old female of African descent, and she had a recurrent upper and lower respiratory tract infections since the age of since her 20s, and she had lung damage with bronchiectasis. So, which immune workup could be done in this patient? So, it's always the same. So, HIV serology, determination of immunoglobulin level, and serology to specific antigen. And so, the patient did not add any lymphopenia. She had a mild hypogammaglobulinemia. And also, surprisingly, the level of IgG to tetanus toxoid were normal. Despite this mild abnormality on the first line immune workup, an immune phenotyping in the patient was performed, which found a profound B-cell lymphopenia. And so as there are abnormalities on this first line immune workup, we perform additional lab tests, and in particular the determination of naive TCD4 and TCD8 cells that were almost absent in these patients. And even at the age of 50 years old, you're supposed to have more than 0% of naive TCD8 cells, for instance. So it was quite atypical, but in this case, what we aim to use in the clinical laboratory robust markers that can be easily performed. And when there is a patient with a decreased percentage of naive T cells, in which we suspect a combined immunodeficiency, there is a lab test that we like, that it's called the study of V-alpha 7.2 positive T cells. And in this patient, it was at 0%. So V-alpha 7.2 T cells it's been published as a sensitive and quite specific marker of combined immunodeficiency due to deficiency in VGG protein. And we perform a genetic study in the patient, and surprisingly, we discover at the age of 60 years old an hypomorphic RAC2 deficiency. And so this is I think interesting, because as you may know, a complete autosomal recessive RAC2 deficiency can underlie severe combined immunodeficiency with complete lack of T and B cells. But depending of the residual capacity of RAC2 to let the adaptive cells to differentiate. There is a whole spectrum of immunological and clinical presentation, ranging from severe combined immunodeficiency, Omenn syndrome, combined immunodeficiency with various presentation, as well as isolated TCD4 lymphopenia. And even here in this case, we were even at really at the extreme of the spectrum with a lack of lymphopenia in the patient. So just to tell you that to be systematic, even in aged patients, to perform these investigations, to perform a patient that have an hypogammaglobulinemia unexplained, this patient should have at least once in his or in her life the determination of naive TCD4 and TCD8 cells. So another cases of classical immunodeficiencies that was with a quite unusual presentation. It was a young adult, originally diagnosed with common variable immunodeficiency at the age of 2 years old, because he displayed normal TB and NK cell count. And he had a normal level of IgM, but an absent level of IgG and IgA. He was thus supplemented until the age of 20 years old with immunoglobulin, and he had no other medical history. However, at the age of 20 years old, he started to display elevated transaminase. And this unmasked sclerosis cholangitis that requested a liver transplantation. And the patient actually had cryptosporidiosis. And we end up finding that he had CD40 ligand deficiency. And that is a combined immunodeficiency and not a common variable immunodeficiency. And this is a bit unfortunate, because when the patient present with cryptosporidiosis, they are more tricky to bone marrow transplant. And it's just to tell you that it may worse to perform genetic investigation even when it looks like a numeral immunodeficiency in a children, to exclude a combined immunodeficiency. So another quick cases. So this time it's not an adult, it's a 2 years old patient who present with EBV driven Hodgkin lymphoma. So Hodgkin lymphoma, it doesn't exist at the age of 2 years old. It's if a patient has a Hodgkin lymphoma at the age of 2 years old, it means he has an immunodeficiency. And the patient was a male. So it could be due to various immunodeficiency associated with impaired control of EBV, such as, for instance, SAP-Purtillo syndrome. However, in this patient, with just very basic flow cytometry marker, we made the diagnosis within 1 day of a CD27 deficiency. And so this is a marker that is usually present in most of flow cytometry panel. So as you can see, the patient does not express CD27 at all, neither on his B cells nor on the CD19 negative cells, such as T cells, conversely to control. And this is important because if in case of an Hodgkin lymphoma, what could have been performed in the patient will have been chemotherapy. However, the patient will have relapsed a few years later. So in that case, I think what was performed in the patient was maybe chemotherapy to reduce the lymphoma, but then an hematopoietic stem cell transplantation. So another cases. So this time we go back to adulthood. To adults. So it's a male of 17 years old who display alteration of general condition, vomiting, fever, and diffuse purpura and circulatory failure. So of course the diagnosis is diagnosis of purpura fulminans. And indeed, what is will be ultimately documented in the patient will be Neisseria meningitis strains. So in case of an invasive bacterial infection, so first of all, we will recommend to perform an immune workup after a single episode of invasive bacterial infection, such as meningococcal or pneumococcal disease. So the immune workup to perform is always the same: HIV serology, complete blood cell count, and serology to antigen. But in the case of bacterial disease, we also recommend to perform a screening of OL Jolly body, as well as a determination of complement activity. So complement system is a proteolytic cascade composed of three different activation pathway: the classical pathway, the alternative pathway, and the Mannose pathway. So and it ends up with a common terminal pathway. And there are two lab tests that can be performed to do a complement workup in a patient with an invasive bacterial infection. The one is a determination of complement classical pathway activity and common classical common final terminal pathway. It's called with a lab test called, for instance, CH50. And there is also to investigate the alternative pathway and the common terminal pathway, IP50 activity. So it's a bit like for hemostasis with endogenous and with the two pathway for hemostasis. So in that case, what was performed, this workup was performed in the patient. So he had normal blood cell count, no OL Jolly bodies, normal humoral workup, and normal CH50 activity, as well as normal level of C4 and C3. So should we stop the investigation there? So the answer is no. It's really essential to perform also a determination of AP50 activity. Why? Because it's the only way to investigate for inborn error of the alternative pathway, such as properdin, factor B, or factor D deficiency. And the patient is a male, and the most frequent alternative pathway deficiency is an X-linked recessive disorder. And indeed, in this patient, in this family, there was some history on the maternal side. So and properdin pathway properdin deficiency, it will be underlie a very severe meningococcal disease that can be prevented with mostly with vaccinations. So we really recommend to do after a single episode of invasive bacterial disease. We think that it could justify to do an immune workup. We have other colleagues in France who have conducted several studies to prove this, also in adults. So it's justified in children, but also in adults. Complement deficiency are one of the most frequent immunodeficiencies. So if you're a pediatrician or an adult physician, and that you do a complement workup to patients you see that have presented such invasive bacterial disease, you will for sure diagnose some during your career. And if the patient, if the complement workup is also normal, as well as basic humoral investigation, it may worth to, if you have access to it, to screen for a specific polysaccharide antibody deficiency. That can mean screen, for instance, by determination of hemagglutinin antibody. And this entity really can really underlie also recurrent infection to encapsulated bacteria. So all of this was a bit of a selection of immunodeficiency due to germline variant. So it causes inherited disorder, and most of the time it can be the onset is during infancy or early childhood, the first symptoms. However, even if the diagnosis is sometimes a bit delayed, as we have seen in the case presented there. However, if we take any infectious disease such as tuberculosis, there are, if we have a look to the incidence of any infection disease according to age, there are always two peaks. Usually there is a peak during infancy, which is believed to correspond to primary exposure to the microorganism during the first years of life. Then there is, and in most of the time, we manage to successfully identify an inborn error of immunity caused by germline variants in these cases. However, there is also a second peak that occurs later in life, and which is believed to be caused by immunosenescence of the immune system. And the question that we can wonder is whether it could be caused or not by some phenocopies of immunodeficiency. So phenocopies or immunodeficiency are immunodeficiencies that are not caused by germline variant, but they are either caused by somatic variants or by autoantibodies to components of the immune system. And we will have a look to some example here with two cases. So the first cases is a patient, is a 52 years old male patient living in Argentina, and he presented a first severe infection at the age of 52 years old with loss of weight, fever, with this skin lesion too, as well as organomegalies with adenomegaly and hepatosplenomegaly. And what was ultimately documented in culture of cutaneous lesion as well as from a kidney synovial fluid was histoplasma capsulatum. So the patient presented severe disseminated infection to histoplasma capsulatum. And 1 year later, he also presented a disseminated infection to low virulent mycobacteria, to a non-tuberculous mycobacteria, Mycobacterium avium. And this was really invasive because it was documented in a lymph node. And the patient had normal basic immune workup. So what additional lab tests could be done? So in that case, what was done was a screening of neutralizing autoantibodies to interferon gamma. So the patient has presented two severe infectious disease by intramacrophagic pathogen, histoplasma and then by Mycobacterium. What's important for the defense to this class of pathogen is really interferon gamma. So what was performed in the patient was a screening of neutralizing autoantibodies to interferon gamma, with the first determination by ELISA, as well as later a confirmation by the neutralizing assay. And what was found is that the patient display neutralizing autoantibodies to interferon gamma. And it's really a phenocopy, for instance, an inherited, a complete inherited disorder in interferon gamma itself, which in which we observe in children, in affected children, also severe susceptibility to recurrent and life-threatening infection to intramacrophagic pathogen. So this was done in collaboration between the research lab as well as Laura Perez in Argentina, and this case is really interesting because most of patients with autoantibodies to interferon gamma that have been documented so far are really from Asia. And as you can see, so I think this is the first documentation of a case in Latin America. And in addition to that, almost all patients reported have a history of infection to non-tuberculous mycobacteria, or to fungus prevalent in Asia, such as Talaromyces marneferi. But I don't think that there are that many cases of histoplasmosis reported in patients with anti-interferon gamma antibody. And so this is important for the treatment of the patient, also for the anti-infectious treatment, because the patient needs, of course, ideally anti-infectious drug against histoplasma and mycobacteria, but to try to restore immunity, natural immunity to this pathogen, he also needs ideally a B-cell depletion therapy. So this can really have an impact on the treatment, also on infections that are really difficult to treat, especially when they are disseminated. And a last case is this one. So it's this one we identify it in France. It's 73 years old male patient who had a history of diabetes and cardiopathy, and the patient is doing a lot of cascade with scars, and it's his job actually. And during a cascade, he hit himself with a stone, and this result to the formation of an hematoma that ultimately fistulizes and lead to an abscess and a necrotizing fasciitis. And during intraoperative sampling, what was documented was nocardia abscessus as well as Pseudomonas aeruginosa. And the patient was transferred to the infectious disease department. So, despite the fact that this infection could be labeled as inoculation infection following a trauma with a stone. An immune workup was performed that was overall normal, and we thus also perform additional lab tests to try to document a susceptibility to infection. And in that case, what we screened was for the presence of autoantibodies to GM-CSF. And the patient actually had high titer of anti-GM-CSF antibodies. This can be of medical relevance for the patient because we know that it can also underlie pulmonary alveolar proteinosis. So a follow-up of his lung will be performed. And anti-GM-CSF antibodies, they can indeed underlie susceptibility to severe nocardiosis in adult in adult patients, but it's been also reported to be associated with infection to Cryptococcus, such as is in case series from our Colombian colleagues. So an adult patient with an unexplained crypto infection to Cryptococcus or severe nocardiosis, it's really worth to screen for these autoantibodies. So autoantibodies to cytokine are really a hot topic. The hottest topic recently was about autoantibodies to type 1 interferon that can underlie susceptibility to life-threatening infection to many RNA viruses. So they can underlie susceptibility to viral pneumonia, of course, to SARS-CoV-2, to influenza also a bit, but they can also underlie susceptibility to rare viral encephalitis, such as West Nile virus encephalitis, and other encephalitis due to single strain RNA. And last but not least, they can also underlie adverse reaction to yellow fever vaccine. And I think that from what we have documented in the research lab, almost 100% of adverse reaction to yellow fever vaccine are caused by either autoantibodies to type 1 interferon or inborn errors of interferon alpha type 1 interferon pathway. So autoantibodies to immune system can underlie various infectious disease. So we have mentioned anti-interferon gamma antibody, autoantibodies to type 1 interferon with viral disease, anti-GM-CSF antibodies with infection susceptibility to infection by Cryptococcus and nocardia. There are also antibodies to IL-17 in recurrent chronic mucocutaneous candidiasis, as well as anti-IL-6 antibodies in patients with recurrent Staphylococcus aureus infection. There are also anti-complement antibodies that can phenocopy an inherited complement deficiency, as well as antibodies to neutrophiles that can phenocopy a neutropenia. And also in adults, a severe infection can also unmask a syndrome that is called a good syndrome, in which there is a thymic neoplasm as well as associated with immunodeficiency. And in this patient, there are autoantibodies to almost everything, and this can result in severe infection. So overall, these various cases have illustrate you the importance of basic screening tests to conduct the investigation of an immunodeficiency. So the definitive diagnosis of immunodeficiency is by documenting either germline or somatic variant, or by documenting neutralizing antibodies. And do not forget that the definition of an immunodeficiency is really made at clinical level. Even if basic or even advanced immune workup are normal, this does not exclude an immunodeficiency. So thanks again for the invitation, for the listening. Happy to take any question, and I give the floor to Racinta, who will present additional, I think, interesting cases of inherited immunodeficiency as well as phenocopy.
Thank you, Jeremy, so much for your presentation. It was great. I'm really impressed with your cases as they truly reinforce the notion that immunodeficiencies can manifest at any age, including elderly. Furthermore, they highlight this variable expressivity between the patients and between the genetic variants. And of course, the work that we have so far with Phenocopies is increasing every day. So I'm really impressed with the case. Thank you for sharing with us. Now we have the time for Dr. Jacinta.
Yes. Okay.
Thank you.
Okay.
Good morning, everyone, and good afternoon. I see there are some people in Europe too. I am happy as well to share with you the time. In this opportunity, in this opportunity, Alberto asked us to show some cases, and in particular concerning the adult patients. I will share the. You see my slide?
Yes, doctor.
Okay. As previously mentioned, Alberto asked us to show some cases for immunodeficiency in patient with we had and delete or maybe several problem to arrive to definitive diagnosis. In particular, in my talk, I will focus the attention in the deficiency concerning the NADPH oxidase complex. As you know, I will just remember you the component of this complex. This complex is constituted by multiple enzymatic protein. In particular, this complex is present in the myeloid or phagocytic cells, and there are some protein present in the plasma membrane and also in the membrane of the granule, and in the cases of the neutrophils. This complex is formed by GP91 FOX, P20 FOX, and also an chaperone called Eros. In addition, there are other cytosolic protein, P40 FOX, P47, and P60 FOX, and also the small GTPase protein. The objective of this complex is to activate it when there are an inflammation or an infectious disease. And the principal part is to produce the reactive oxygen species, or ROS, in particular superoxide and hydrogen peroxide. And this is why that we indirectly measure in the diagnosis laboratory using the dihydrorhodamine or DHRS. The rhodamine 1, 2, 3 is a fluorescent molecule, and one is in presence of the cell, and for example, on forward ester like PMA, the cells can produce the ROS, and we can measure by flow cytometry. And you see here in the table, you have the picture concerning the DHR by histogram. All of the finding in the left suggests a negative result, in contrast to the finding in the right panel, suggesting that this part is positive. And this is the cases, for example, in the healthy control, when the cell are activated, the cells move to the right, and this is the cases of the healthy control. However, in patients with a chronic granulomatous disease, which is the most frequent disease in affecting the NADPH complex, the cells, the pattern remain the same, non-stimulated versus stimulated with an forward ester are the same, all in the left. One of the cases that is particular is the CGD with an X-linked transmission, in which mother of the patient have two peaks, suggesting that the mother have one X with the wild-type allele and the second with the mutated allele. And this is why that we can measure, in particular, using the neutrophils. And we can see, for example, in this pattern, that chronic granulomatous disease is the most frequent, and they can affect any of the protein of this complex. And in terms of the clinical disease, this disease is characterized by three components. One is the infectious disease, characterized by the early onset severe bacterial, including pyogenic and mycobacterial disease, and also fungal infectious disease. The second component is the inflammatory manifestation, and first and finally, the autoimmunity. Chronic granulomatous disease can be divided or classified in two parts. The first is classical CGD, and the rest is the variant CGD. This classification is made according to the result obtained in the DHR, and in particular when we focus in the neutrophils. But classical CGD have also an abolished or very, very impaired production of the ROS in the monocytes, macrophages, dendritic cells, and ABB cell line. In the variant CGD, that is the cases of the immunodeficiency P40 we can observe an impaired but very little impaired production of the ROS in the neutrophils and unvariable affection in the macrophages and the monocyte. And particularly, these two variant CGD patients have more autoinflammatory and autoimmune component. PKC delta is also considered CGD because intrinsically ROS is affected. And finally, GP91 Fox MSMD is not CGD, but patients have a high predisposition to mycobacterial disease, in particular BCG and Mycobacterium tuberculosis. And variants are in the germinal inheritance, but functionally, the only cells that are affecting are macrophages and ABV cell line. And in this context, I will show you 4 particular cases. For the classical CGD with the patient with the pneumonia due to Staphylococcus aureus and zero activation in the DHR, I don't show you. I choose to focus in three particular cases of the germinal CGD, and finally, the fourth concerning the somatic CGD. Clinical manifestation of the CGD, of the classical CGD is, as you see here, will affect several organs and several systems, and in general, the most important microbes are the pyogenic bacteria, mycobacterial, and the fungal disease. But also parasitic infectious disease has been reported in the CGD patient. The clinical presentation here concerning an boy from Georgia. This patient lives currently in France, is from a non-consanguineous family, and as you see here, patient received a BCG vaccine at the birth, and at 11 months, he developed vesigitis concerning only an axillary adenopathy, which has been treated by for antimycobacterial drug and with a very well response. However, at 4 year age, patient presented fever, asthenia, otalgia, and otorrhea. With this clinical manifestation, patient had a diagnosis of mastoiditis. There is in an hemogram and neutrophilias affecting more particularly neutrophils, and with an C reactive protein very high. But 1 week later, patient presented partial seizure of the left arm. Then patient was hospitalized, and in the magnetic resonance imaging, multiple brain abscesses were observed, and the patient received empirically the treatment with antibiotic, suggesting that probably the cause was the bacterial disease. However, when patient had the cerebral biopsy, the patient had a diagnosis of the amoebic cystic infection caused by Acanthomoeba parasite. With that, the patient had a suspicion of the immunodeficiency. The first laboratory showed a normal lymphocyte count concerning also the different subset of the lymphocyte, including T, B, and Engel cells. The immunoglobulin dosage showed an hypergamma-globulinemia, in particular for the IgG-AGA. And when the patient had the result of the DHR, we observed an abolished NADPH oxidase activity in the neutrophil, suggesting an diagnosis of the CGD. In addition, when we perform the staining of the cytochrome B55A, we did not observe any expression of this complex. However, the mother has two peaks, suggesting that the transmission of this disease was X-linked and concerning the genetic disease caused by the variant in CYBB gene. In terms of the genetic disease, indeed, we identify a nonsense variant in CYBB. Patient have been treated for this parasitic disease, and with this diagnosis, we check in the literature, and we observe, in fact, that the parasitic invasive infection has been reported in the inborn error of the immunity, in particular in the CGD by GP91 Fox, or also P20 Fox, P47 is very important, in particular in Latin America, to have this diagnosis, because, for example, in some parasitic infection like Leishmania or Toxoplasma can help the clinician to determine what is the problem in terms of the immunodeficiency. The second case concerns this boy. Is a French from a non-consanguineous family with a diagnosis of the Guillain-Barré syndrome. During a long time, the patient had the recurrent pneumonia and the leishmaniosis, and she has the pulmonary granulomatosis without positive culture in terms of the pyogenic bacterial, mycobacterial, and fungal disease. Guillain-Barré syndrome is an autosomal dominant trait caused by an contiguous gene deletion located in the chromosome 7. The clinical disease of this patient are characterized by an development delay, cardiovascular abnormality, and particular phases, as you see here, hernias, musculoskeletal defect, hypercalcemia, but also a percentage of these patients can also suffer from the infectious disease. And as you see here, you have the genetic disease is a copy number variant, as mentioned previously, in the chromosome 7, and the gene here, NCF1, is the most frequent gene affecting in the autosomal recessive chronic granulomatous disease. It's important when you have the diagnosis of Guillain-Barré syndrome to check by DHR-S if the patient have the CGD. And this is why we perform the DHR. And if you observe here, the pattern is a normal. If you compare the picture generated in the healthy control and using the neutrophils. The neutrophils of the control can produce correctly the ROS. However, the patient does not produce correctly the ROS, suggesting a diagnosis of the CGD. In terms of the genetic disease, we perform two different tests. One of them is the target panel sequence, including the gene of the CGD. And if you observe here in the red, this is the pattern that we observe when an homozygous deletion affects the gene. This is the cases of the patient because the patient had, unfortunately, an homozygous deletion affecting the NCF1 gene. This is the picture of the target panel gene. And in the right, you have also the picture concerning the whole exome sequence that we confirm that the patient have an homozygous deletion of this gene. Future studies are necessary because, as mentioned previously, Guillain-Barré syndrome is caused by an heterozygous deletion. And the most frequent to find is to have a second second genetic event in this gene, but affecting the exon 2, in which there are frequently the GT deletion. In the cases of this patient, we have an homozygous deletion. For the moment, we don't know if it's because patients have an inheritance of this deletion, or for twist by one of the parents, or if the parent have also one of the Guillain-Barré syndrome. For the moment, we don't know what is the mechanism of this one, but for you, it's very important to check in this patient and second genetic disease. The first diagnosis concerning this patient. This patient is a female born in La Réunion Island, and she had the antecedents of the recurrent pneumonia. But also at the 10-year-old, she had the diagnosis of the vasculitis lupus-like versus sclerodermia. She had also a raynaud venom and also a kyst. After that, at the 21-year-old, she received the diagnosis of the bipolar disorder. She had an antecedent of the cannabis addiction and the pulmonary manifestation. With this, altogether, clinician suggested that the pulmonary manifestation were due to the hypersensitivity of cannabis and the patient receiving treatment with steroids. At the 44-year-old, she was received also in consultation in the hospital due to different pneumonia. She was hospitalized, and when the physician performed the pulmonary biopsy, the diagnosis was changed by necrotizing granuloma without a definitive diagnosis because it was not clear between the infectious disease, and in particular mycobacterial disease, or any other any other etiology. Physician asked us an opinion, and with this one, we suggested that probably a primary immunodeficiency was involved in this patient. The TB NK cells was normal, as well the level of the immunoglobulin. However, when we performed the DHR, only 5% of the neutrophil produced a frost open PMA activation, suggesting that the patient had a chronic granulomatous disease. And as she was female, we performed directly and target panel gene. Focus your attention in an autosomal recessive inheritant model, but for your surprise, patient had an heterozygous nonsense variant in CYVV, which is known as deleterious in response of the chronic granulomatous disease. This is very important to have documentation here is just to have a very detailed clinical report, because during, as I come back here, the diagnosis, the most or the diagnosis that was retained by during a long time for the physician was the bipolar disorder, and the second, the addiction of the cannabis. And then 20 years later, after the first diagnosis, and without retention of that, she had the vasculitis, the Raynaud-Femur phenomenon, the diagnosis of the CGD was delayed. We need to continue with this patient in the with a more detailed study, because as you see here, the diagnosis is the CGD by X-linked transmission, and probably this patient has an important disorder in terms of the X inactivation in some of the myeloid cells, and probably during her life, she can also change the percentage that we observe in her genetic diagnosis. And finally, I like to present you these clinical cases of a patient, a male patient from Bordeaux. This is a very good, this is a region known in France due to the very high quality of the wine. But now we will focus the attention in this patient. And if you observe, there is, I think, three parts that, or three concepts that you need to retain. One of them is patient received the BCG vaccine without any secondary effect. And during the first half of his life, patient was healthy. The problem starts at fixing ER all with a pulmonary tuberculosis, quantiferon positive. And after that, 10 years later, he developed a cutaneous infection, you see here. And this disease begin at the cutaneous infection, but later was disseminated. The particularly here is that the infectious disease was produced by a very rare fungus, Purpureosum liliaceum. This fungus affected the patient and caused the acute hepatitis, fever, several adenopathy in different parts. And when we look the literature, we observe that this fungus is documented in particular in the immunocompromised patient. These fungus are present in the air, in the soil, in the plant, in the food product. But in the healthy and immunocompetent individual, this fungus is not dangerous. This fungus suggested that the immunity can be affected. And this is why we continued the study. And your strategy was to study looking the different lineage observed in the hemogram, and monocyte, neutrophils, and lymphocytes are normal in terms of the number and the percentage of different components. The immunoglobulin level were normal for the IgE, IgM, and IgA, and including IgE. The only one that we observed a problem was the B lymphopenia, but T and NK cells were normal. And obviously, we exclude the HIV infection because their serology was negative. Surprisingly, this patient with this age had an impaired NADPH oxidase activity because patients have a very, as you see here, only 5% of the neutrophils can produce the ROS correctly. And the majority of the cell does not produce ROS. This is very, very abnormal for the age. But the most surprising finding is the presence of this 5% of the population producing the ROS. The similar result we obtained measuring the expression of the cytochrome B55A. And you see here, healthy control can express correctly on the neutrophils the cytochrome B55A. Patient, the majority of the cells do not express this complex, and only one very minority minority of the population can express correctly cytochrome B55A. This is definitively abnormal, and this is not the pattern that we observe in the male patient. This is, we can observe this one in the female with the unskewed X inactivation, for example, but not in the male. For this one, we continue the investigation, and as you see here, you have the result of the Sanger. It was also we continue performing the whole exome sequence and also the whole genome-wise. This is very particular because if you focus your attention just in the first time, healthy control compared with the patient and only in the whole blood, you observe the wild type sequence here for the healthy control, and the patient have another color, blue change to the red, but a very small population express the blue color, suggesting that the patient has two populations. And if you observe after that the result in the nails and the hair, you observe that the patient have a pattern very similar or directly equal to the healthy control, suggesting that the extra hematopoietic sample have a pattern that the control, and suggesting that probably the patient have a somatic variant in CYBB. We continue with the selection of the different population of the lymphoid compartment and versus the myeloid compartment. And if you observe here, only the myeloid cells are very well compromised in this patient. Neutrophils, monocytes, myeloid dendritic cells, but also plasmacytoid cells contain the somatic variant in CYBB. The T-alpha beta naive, T-alpha beta memory cell do not contain or contain a very, very little amount of the somatic variant, and is more evident in the T-alpha alpha delta cells and the V cells B. This is this situation is observed in the nature. For example, in the majority of the inborn error or the prime of the immunodeficiency are due to the germinal mutation. In these cases, we refer as inborn error of the immunity. And in general, these germinal mutations are present in the egg or the sperm and can be inherited. Germinal mutation can also cause the cancer in familial syndrome, and we can observe, in contrast, some rare somatic mutation. This is important to establish the difference. In somatic mutation, the variant were origin in one individual, but there are not the possibility of the inheritance. This variant, the somatic mutation, we can observe, for example, in the cases of the cancer. We also observe in the cases of the autoimmunity disorder, but is very, very rare. This one, for example, in the cases of the CYVV, this is the first cases reported in the literature. If we observe this somatic mutation, maybe this picture is more is very well to explain that. for the somatic mutation can be origin in any of the age, but it's more frequent in the older age, and this is why we now we focus your attention in the patient with the severe infectious disease. This is possible. This is somatic mutation during long time has been searched and identified in the cancer or in the autoimmune disorder, but maybe this finding opened the door for the discovery of the other genetic disorder, helping us to explain the severity of the infectious disease in this type of the patient. And probably, according to the infectious disease, we can focus in the genetic disease that we can find, and also this one we can explain by the different affection of the progenitor, the lymphoid and or myeloid lineage. That is all for today. I'd like to thank your attention and happy to receive the question if you have.
Thank you very much, Jacinta, for this wonderful speech. Thank you. I think that the cases that you present today were really great cases, from the childhood to the adulthood, especially focus on the adulthood and Phenocopies. So I'm really happy to have this opportunity to obtain these teachings from both of you. So now it's time for comments and questions.
Thank you, both speakers. I will be reading the questions in the chat. There's one question for Dr. Jacinta. The question says, in which cases we need to investigate the failure of NADPH oxidase in a specific cell type, if there is a clinical clue or a particular curve in the DHR test?
Yeah, thank you, Matthias.
Thank you, Sigfredo, for this very nice question. In fact, for the NADPH oxidase, there is a tissue specificity for the NADPH oxidase complex. In fact, for example, if you have an pyogenic bacteria, you can focus your attention in the neutrophils. Neutrophils, if you have a fungal disease, is more neutrophils and monocytes. But for example, mycobacterial disease is more an defect in the macrophages. Indirectly, you can study the monocyte-derived macrophages, but it's not for an clinical diagnosis, laboratory. Sorry. My opinion is that maybe you can start with a genetic test, and after that, if you identify a variant in one of components of the NADPH complex, you can after that construct the history in terms of the functional defect. I think for us, the DHR on the neutrophils remains the most important test for the CGD. This is the most important. And the message is that now you can enlarge the the number of the patient, not only consider CGD in the children. The last clinical presentation suggested that even adult patients can you can perform the DHSC.
Thank you very much for the answer, Dr. Bustamante. I have a question for Jeremy about the first case that he presented, that it was a man of 40 years old with XLA. What do you think about the late onset of this patient? Before the onset, he was asymptomatic or not?
I think he always had a bit of upper and lower respiratory tract infection, but maybe his BTK variant is indeed hypomorphic, a bit hypomorphic, and maybe it was enough to produce a beta immunoglobulin and to survive and until this age. It's always a spectrum of severity that sometimes correlate with the underlying variant and sometimes not. Is difficult to know, but yeah.
Okay, maybe hypomorphic. And the second question is about the technique that you have in the lab for the AH50, because I think that in Latin America, in the majority of the countries, we have the CH50 that is automated from binding site company. But what for the AH50? Because I think that it's difficult to have an automated technique for that. Do you have in the lab, or what is the technique that you are using right now?
So it's true that in Paris lab they are using erythrocyte from rabbit, and it's from a specialized farm in medical product derived from animals. So it's true, it's a bit complicated to perform, but I think there are two reliable options. One of them is from a Swedish company, in which it's an hemolytic test, but where erythrocyte of rabbit are in a agarose plate. And the other option, I think, is also an ELISA from a Swedish company too, I think. And otherwise, otherwise there are still the option also just to do a properdin assessment by ELISA, even if it does not give you insight about the function, and and it does not explore also, of course, factor B and factor D deficiency. It's true that there are some tests that are more accessible than others.
Okay, perfect. Thank you.
But it doesn't work at all to do Mano's activity, because it's useless at a patient level. MBL deficiency, it does not underlie severe susceptibility to bacterial disease.
Okay, perfect. So I don't see more questions in the chat. Or
There's
yes?
another one.
Yes. We have
There's
one
another
more.
one for Jacinta. They ask whether you consider that in cases of male patients with mutations in CYBB with normal DHR test, possible de novo mutation in CIBB, it must be always investigated mosaicism of CIBB.
Okay, good questions. Yeah,
Obviously, when we have mutation in CYVV in the male patient, we will perform as possible complete familial segregation. Frequently, mother is heterozygous for the same variant than the patient. But if she is wild type, we cannot exclude the possibility of the mosaicism, the gonadal mosaicism. Recently, we have cases in which mother had only 10% of the mutant allele identified by Sanger.
Yeah. But we cannot exclude.
Okay.
Alors,
I think
Oscar Paul.
Please comment about the pseudogene and diagnosis of NCF1 mutation. Yeah, another very good question, and it constitute a very big problem for us because NCF1 had two pseudogenes with an homology around 99.8% of the gene and the pseudogene. But the most frequent cause of the P40Fox deficiency is due to the homozygosity of the GT deletion in the exon 2 of NCF1. That is very fast to do that because the sequence is okay. There is not a problem for the differentiation with the pseudogene. For the rest, in the laboratory, we perform directly the target panel gene. But I know that is not the more comfortable position for all of the genetic laboratory diagnosis. As if you remember, I see the picture concerning the target panel gene that we can remove directly during the analysis. We remove the sequence of the pseudogene and just we can localize only the sequence corresponding to the gene. And now the most recent whole exome sequence offer also the possibility to have a very good coverage of the gene. I think it was improved in the last time.
Okay,
thank you, Jacinta.
Matthias, excuse me, and about this same question about the pseudogene, do you think, Jacinta, that is useful to do the functional test of the GP47 Fox in flow cytometry for these cases when we have doubts about an NCF1 mutation?
Good question. In fact, for GP91, P22, P17.5 Fox protein, the antibody available for the flow cytometry work well, very well. However, for the P17 Fox, it's not good. No. We need to perform directly on Western blot, but I don't know if it's available in all of the laboratory. This one is well for Western blot.
Okay, perfect. Thank you.
Thank you again. There's a last question for Jeremy. They're asking whether there is an explanation for the presence of autoantibodies for cytokines in many adults.
That's a very good question, and so far we have some answer for some autoantibodies. For instance, autoantibodies to type 1 interferon, they are mainly linked to inborn error of affecting thymus function. but they can also be due to myasthenia and to pre-thymoma that can happen later in life. But for most of the autoantibodies, we don't know why they appear during life. There must be a genetic explanation, either somatic or germline, because everything is genetics.
And I have a last question for Jeremy also. When talking about phenotypes and phenocopy, sorry, and we're facing a patient with, for example, mycobacterial infections or fungal invasive infections, sometimes it is easier to perform a molecular test after doing all the other immunological assays rather than looking for autoantibodies. So I was wondering, based on this fact that we lack of sometimes these resources, if there's any clue, a clinical clue, or a kind of specific suspicious to make this looking for the autoantibodies.
That's a very good question, and there are not that much clinical clue. It's not necessarily associated with, for instance, broader autoimmunity. Sometimes yes, sometimes no. So it's true that these autoantibodies, even for instance in France, they are mostly screened currently in research lab only, and not yet in clinical laboratory. But maybe the fact that it's ELISA, it made them still quite accessible. And so maybe it will be more democratized in the forthcoming years to screen for them. There are some that are really, I think, important to screen, especially when they are involved really in the treatment. For instance, interferon gamma autoantibodies. This is really essential for the treatment.
And do not hesitate to contact us if you perform the ELISA for autoantibody and you obtain a negative result. It means the ELISA does not suggest the presence of the autoantibody, okay? Because sometimes it was considered as false and is not detectable, and probably the patient has the neutralized autoantibody, but not detected by ELISA, okay? Because probably it was not high.
Okay, and the neutralized autoantibody, do you detect it by flow cytometry?
So we have a bed-based lesionplex, no, bed-based assay, but similarly to what Racinta mentioned, sometimes it's not sensitive enough. It's sensitive in patients with very high titer, but the gold standard is really indeed to do a neutralization assay.
Okay, perfect. Do we have more questions, Matthias? I think no.
No, we don't.
Okay. So unfortunately, we have to finish, but we're very grateful with Jeremy and Jacinta. Thank you very much. Latin America is your home, of course, also. And we hope that this will not be the last opportunity that we have to share our time with you. Thank you very much for taking the afternoon or of your free day in this Saturday to share your knowledge with Latin Americas. And on behalf of the Junior Committee from the Latin America Society for Immunodeficiencies, LACIT, we want to express our sincere thanks to both of you.
Thanks a lot. Have a nice day.
Alberto, for this nice. It was a pleasure for us to share the time, even the afternoon of the Saturday, but the most important is to continue the training of the junior.
And for us, it's time to have a wine of glass in France, you know. And have a nice day. Thanks a lot for the invitation.
Thank you very much. And to finish, if you want, for the people that participate in this seminary, a survey will be sent to the provided email addresses. So those who complete the survey will receive the certificate of attendance, okay, if you want, for the people that join today. So thank you very much. Bye-bye.
For the last we are connected, we have two final announcements. I don't know if we can share the presentation. That's it. So we would like you to join our group. Here we share the web page where you can enter and you can find all the requests for joining the LACIT Junior group. If you can find it here, maybe you can use the QR code. And here is what we need to present just to join us. It could be very useful that you join us because we share all the experience of the most experts, and we can share the activities we do all along the year. And we also have a WhatsApp group where you can join. In this slide, you can see the QR code. So you are all invited to join us.
Okay. Thank you. See you in the next conference.